Sounded like there were lots of great networking conversations over the lunch hours, so certainly great to see everybody back and connecting. So this afternoon, as Jack mentioned, we have some really exciting case studies that are diving into some examples of MSD prevention and embedded into some of these enterprise metrics. So up first, we have Susan Fuciarelli and Janice Jaskolka, and they'll be sharing some insights on integrating business metrics and analytics to sell your case a healthcare perspective. So just a few quick notes, and again, as Jack mentioned, the full bios are all in your portfolio. But really excited to have Susan with us today. Susan's been a long-time advocate and supporter for CRE-MSD, so Susan, thank you for all of the continued support. She's also the Director of Health and Safety and Wellness at Hamilton Health Sciences. She's a certified disability management professional through the National Institute of Disability Management and graduated with honors from the OHS program at Ryerson University. Janice is an ergonomics program specialist at Hamilton Health Sciences, has her honors Bachelor of Arts Kinesiology and Phys Ed from Laurier and Masters in Human Kinetics from the University of Windsor, and is also a CCPE with 15 years experience. Please welcome me in joining Janice and Susan.
Well, good afternoon. How was everyone? Yay, yay. Nobody's in a food coma? That was a lot of food. A lot of heavy food. So we're going to have a very exciting presentation for you. And so we're going to keep you awake and we're going to keep you interested. And certainly if you have any questions, we are looking forward to fielding those at the end of the presentation. I have rather the easier part of this presentation in that I'm going to do the beginning and then part of the middle. Janice, my colleague and ergo extraordinaire, is going to do all of the heavy lifting with the stuff that you really want to know about. So thanks for having us here, Jack. Thanks for inviting us back. We're always excited to be part of CRE-MSD. I've been affiliated with CRE-MSD for almost 20 years now, prior in my role at the WSIB, and I don't know, they just kept asking me to stay on the advisory committee in the different capacities that I've had over the years, so it's a really exciting partnership, and I'm glad to be here. So without further ado, we are going to be just talking about these objectives with you today. So we're going to identify the key actions that really enabled us to get the buy-in from senior leadership. I'm going to tell you about Hamilton Health Sciences in a moment, and you'll see how large this organization is. And so getting that buy-in from your senior executive team is paramount in order to be able to execute any kind of strategy. We're going to share some examples of the metrics that were used and how we collected them. We're going to recognize the benefits of organizational alignment because, again, you can't do this alone, right? It takes a village and it takes an entire organization to move the needle forward on prevention. And we're also going to demonstrate advancements made in our MSD prevention program, and we're also going to talk about psychological health and safety at HHS too. So similar to what Jack had been mentioning, he's no longer there, I'm pointing to an empty chair, just on that total worker health, right? So we've started to look at that and started to integrate that into our programming as well. But as I said, it does take a village, and I'd just like at this time to recognize my other colleagues that are sitting at this back table here, because in addition to Janice, we're very fortunate that we have 3 ergonomists on staff at HHS. Janice is the ergo program lead, and then we have Hollins Chan, and we have Alex Mason, and they are also ergos at HHS. And although I didn't know it until he showed up here today, the safety manager is here as well, Steve Jameson. So thanks to all of you for your contributions in advancing this work for us. So who is Hamilton Health Sciences? We are a very large organization. We have 5 main hospitals and 5 specialized centers. So we do regional programs such as cardiac and stroke, palliative care, cancer care, and pediatrics through our McMaster Children's Hospital. So we have around 15,000 staff, physicians, learners, volunteers. So again, a very large organization that's spread out over our region, which includes the Juravinsky Hospital, the Hamilton General Hospital, McMaster Children's Hospital, and Women's, We've got the West Lincoln Hospital, which is out in Grimsby, and St. Peter's, which is our palliative care and elder care center. So we are the only hospital in Ontario that cares for all ages from pre-birth to end of life, so quite unique. So this is just to give you an overview. I know it's kind of difficult to read, but you will be able to see this in this slide deck. So rather than doing an org chart per se, we've sort of broken this down into functional responsibilities within the three teams. So you'll see the pink boxes are the separate and distinct teams within health, safety, and wellness. So we have safety and ergonomics, wellness, ability and attendance, and employee health services. And then under each of those, it just sort of gives a description more so of what the accountabilities are. So we have a total of about 45 staff in the organization to service all of those 15,000 people and all of those different sites. There are 3 managers. We have a team of 6 safety specialists, a fit tester, a hygiene specialist, our 3 ergos. We have 2 healthy workplace coordinators. We have 21 attendants and case managers who deal with all of our disability management pieces, WSIB, et cetera. And then we have 7 employee health nurses. So what some may consider a fairly large team, but again, when you consider the scope of work that is required from this team, we are small but mighty. So some of our key accomplishments, we have, again, through the program that we've got in our MSD prevention, our Safe Patient Handling program, we have had about 4,500 staff that have been educated in that Safe Patient Handling program since 2016. We do that through our initial employee orientation, so for health professionals, and then also through identifying where our highest risk units are as it relates to patient handling. So we've taken, again, somewhat of a strategic view to those different areas where we've got those risks, and over the course of the years, by sort of highest risk and then decreasing risk from there, we've targeted about 5 to 6 units every year. And so through the course of that, we have managed to educate and train all of those people. COVID was a real treat in the hospitals, as you can imagine. And that really did put a kibosh on some of our in-person learning, just because we couldn't bring people together, and it was very difficult to not only bring people together, but even to have the resources in order to do the education itself. So we did end up having quite a considerable backlog in that training, but again, through the efforts of our ergo team, as well as our consultant at Arjo, we were able to educate over 600 staff in a 4-month period at the end of 2022. So that was really quite an accomplishment. And again, I want to just acknowledge my team for all of the work that they did there. We've also invested quite a lot of cash into the system. So about $4 million has been invested into equipment and education. Most recently, a commitment of $1.5 million was to support the replacement of aged ceiling lift motors. We also, up until recently, were part of the WSIB safety groups, and when we got those safety group rebates, and for us they were usually in the neighborhood of about $300,000, $350,000, we had a commitment from our senior leadership team to reinvest 100% of that rebate into our health and safety and wellness programs. So again, really great commitment. And so you can see here that through the education that we've done, we have seen a 45% reduction in reportable MSDs. So those are our lost time and medical aid MSDs since we started that program in 2016. And we've completed, now that the safety groups is over, but now we have the Health and Safety Excellence Program through the WSIB. So we just completed our very first run at that. So we had 4 different topics that we worked on. Sorry, I'm going to have to refer to my notes. So we had networking and peer learning, latex control, our behavior safety risk program, which is our workplace prevention program as it relates to risks that patients bring because of different behaviors, be it responsive or other types of behaviors. And then bariatric equipment request process. So this was caring for our patients that have bariatric needs. So we had those 4 topics. We worked with our consultant at PSHSA, Shelley Hurry, and we were able to submit those 4 topics, and we got a complete green check mark on all 4 topics. So considering it was our first time being involved in the program, we're pretty darn proud about that. So of course, as I've said, getting buy-in from your executive team is really key to any kind of success in both health and safety and in wellness. And so we're just going to sort of show you the journey or tell you about the journey that we embarked on, right from sort of the concept and then through how we kept our senior leaders engaged and how we were able to participate with our teams, with our organization, with the managers, with the directors, and be able to advance this work. So it's not just about signing a policy. You can have a policy and it can be on your intranet or it can be in your binder collecting dust. It's really how do you make this live and breathe? How do you really bring this to life and make sure that people are following this? So it gets to that behavior. It gets to creating that culture within the organization around health, safety, and wellness in order for this to be successful. So at this point, I'm going to turn it over to Janice, who's going to take you through the journey.
Hi, everyone. Thanks so much, Susan. So really, when we're thinking about the starting line, where did this all begin? And I, like many of you, a practitioner, sit in the audience. This is really overwhelming to think where to start, what to do. So I'm hoping I can give you some guidance on what we did and what worked, maybe what didn't. And really, the starting line for us was really truly that environmental scan, getting an understanding of what is actually going on in our organization and where we can make an influence. So really, I want you to think of 2 questions. You sitting there thinking about your organization and what changes you want to make. Think about what is the current state in your organization? What's everyone doing right now? Where does my work fit in? And what is going on in peer organizations or the sector in general? What's everyone else doing and what's working for them or not? Because really, that's where we started. To give you an idea of what I mean by an environmental scan, there's kind of 3 bins of information we really looked at when we were collecting this information, trying to understand where do we want to go. They kind of binned into what was the root cause, what's the problem, why is this happening? The needs, what do we need in order to implement our change and to make it successful? And are there any gaps out there? Is there anything that we're seeing that we need to address to make sure we're leveled up to be it legislation or anything of such? So let's explore a little deeper. When we talk about root cause, what can we look at here? I think most of us in this room probably first went to what injuries are we seeing or what incidents have we experienced in our organization? And really that's pretty helpful and easy information to collect. I think almost everyone in this room can say, yes, we have injury information, right? We probably wouldn't be here today if we didn't. So we can use that information really to help us prioritize, to understand, where can we focus our work? You can look at risk assessments, be it, are they ergonomic assessments, they can be job hazard analyses, anything that your organization also has done to identify where hazards are present. Our joint health and safety committees are also excellent resources. They do their own inspections and they may have highlighted areas for improvement. And really I want to elaborate on the staff feedback component. It came up so many times today and I can't tell you how important this information is. I think in every ounce of work we do, the worker voice has been heard and we try to address their concerns. So really staff feedback collected through surveys, focus groups, anything of nature where you can get that voice is really important when you're wanting to understand the why things are happening. When we look at needs, this is where we want money. So resources. So when we talk about resources, we're talking about people power, we're talking about equipment, we're talking about technology. We're looking at all those resources that are required to move that needle forward, as Susan mentioned. We need things. We need investment in order to move forward. There might be some low-hanging fruit we can address with minimal funds, but the reality is to make big change, you need big investment. Infrastructure is another need we have. So when I think about infrastructure, I think about physical design of space. Sure, it's great to want to make a change, but if I don't have the physical space to make that change in, it's not going to happen. But also space itself. And what I mean by that, when we talk about training, for an example, our training program would not function if we didn't have dedicated space to store equipment, to bring staff to educate them. Because if anyone stepped in a hospital, I'm going to tell you there's not a lot of space to do much of anything. There's beds in the hallway, there's people running around. We can't train in units. As much as we try to, it's very difficult to give the type of education, hands-on education that we want. One big need as well is organizational readiness. Is your organization ready to take on a change? Because let me tell you, if they're not, it's not going to happen. No one's going to have the time to listen. No one's going to have the interest to listen. So you really need to do that scan and understand, is it the right time? It might not be now, but you might see something else that's going on that you're like, that's something I could piggyback off on in a few months. Let them get the ground running, and then you can go follow that work. For gaps. So gaps, we're looking at standards and regulations. What is out there that maybe there's a gap we want to identify to level up? Maybe it takes a visit from the MOL. Maybe they're going to let us know what our gap is. Maybe we've seen something in the Green Book. Maybe it's in the MSD prevention guideline. Maybe there's something we've seen that we can pull that into our environmental scan and share with leaders. Doing a literature review, looking at leading practices. If anyone's been on the MSD prevention guideline website, there's an excellent resource library. And in there, you can look for tons of information, and it can help you understand what are some of those leading practices available. And then lean on your peers. Look at your peer organizations and benchmark what they're doing. They may identify a ton of gaps. Maybe they're having the same challenges. And when we did patient handling, yes, I don't think there's a hospital we didn't talk to that had it solved and perfectly resolved in their organization. So yeah, we can talk to each other, we can understand what each other is doing, and again, that helps our leaders understand what the scope of work required is and where there's gaps in the industry. So as we talk about this environmental scan, we're talking also about what metrics. What can we pull from that data we collect that we can then share and sell to senior leaders so they understand why we have a problem and why it needs to be fixed? How many people in this room have a strategic plan with their organization? Awesome, that's your best friend, okay? Understand what those organizational priorities are and align to those opportunities. So where you could pull your work in. We heard it this morning, and it's the exact same thing we've heard. Where can you fit in? Where can you slide under the rug and get your foot in the door, right? And with the data you want to think about, we have that quantitative data. And I think everyone thinks about metrics as being quantitative. And yeah, it is. It's numbers, right? So it's measurable. It's something we can count. There's quantitative data. And that's all good. But the qualitative data validates it. It gives us the why. It lets us understand. So don't push the qualitative data aside. Take it, use it. Look for those themes, and what I've learned is quantify it. They want numbers, I'll give you numbers. So take the information you learned, look for those themes, quantify it, and sell it that way. So here's some examples of metrics we've used for various projects, and this is spanning almost 8+ years now of work. We've used various things. So when we've been in the safety world, we've got our MSD-specific injury rates. So we've teased out all of the injuries in our organization and focused just on those that are MSD-related. We could look at what are the WSIB claim types. So is it a lost time? Is it a healthcare aid? What is it? We could look at injury severity as well. So days lost or modified days. And that really comes to play later too when we want to talk about return on investment, calculating cost. Those days are really important because they add up and they cost a lot of money. Nature of injury. This is really how you're going to define your scope of work. Because remember, this is overwhelming. Everything we're talking about, it's a lot of information. But if you want to narrow it down somewhere, when you look at the nature of injury, that can be kind of your starting block to understand, okay, there's a problem here. Let's dive deeper from there, and so on and so on. Another metric we've used is getting that staff perception of safety. So we do annual engagement surveys with our staff in our organization, and we get an overall feel of what they think safety is in the organization. But we've also worked with our staff to conduct focus groups or surveys and just say, hey, do you think you feel safer using this product than you did before? Or how safe do you think you feel now that we've made this process change? So getting that staff perspective of safety can be a very valuable metric. Cost. It's pretty simple, right? This is probably the one that's most simple. Not really. Depends how your organization collects information and tracks it, right? But direct injury costs, like what we talked about today, can be a valuable source and a metric. So are you seeing increase in costs, decrease in costs? And when I talk about costs of injuries too, we also need to consider what costs the organization is going to have to put into. So we definitely want to capture what our resourcing costs are going to be, equipment, education, anything of sort. You need to have those numbers. Because ultimately, to determine a projected cost savings or ROI, we're gonna need both sets of data. We can't just say we're gonna save you all this money and you don't have to spend a penny, because really that never happens. Productivity. I think when we think in healthcare, I know for me, I really struggled with thinking about how productivity fits into healthcare. And I mean, there's a lot going on right now with simulations and things like that, but as a practitioner in a hospital, I probably am never gonna stand near a nurse and say, okay, I'm gonna time you, go. The look I'd probably get, we're not gonna do that. But there's different ways we could think about productivity. And we've used a lot of staff feedback when we talk a lot about productivity. One thing, when we're making a change, think about the workflow and analyzing that workflow. If I brought something closer to a staff member, I'm probably saving them time in the long run. Not only have I decreased their reach, I'm saving them time. We've asked staff in surveying, what do you think? Do you think that introducing this control has increased the time it takes for you to perform the task, decreased it, stayed the same? So we're asking what the perceived time savings is. In an environment that is so lean and time-strapped, resource-strapped, we want staff to feel they have time. A lot of times they do, but it's that perception of I've got to take this vital, I've got to distribute this med, I've got to go to this meeting, I've got to do that. There's always this pressure for time. So asking staff their perception is really important. How easy it is to use equipment, or to follow a process, to implement information, or to take and use information. Asking staff how easy it is, that's another concept when we think about productivity, because the easier it is, more likely the easier their job's gonna feel and they have the time to do it. And also perceived accessibility. So we did this with our patient handling program, and it's one of our standard questions on our survey when we implement, is asking staff, you know, since we've made this change, how accessible is the equipment? And shockingly, we've changed nothing, but they perceive the equipment's more accessible, just because maybe now it's labeled in the room or the equipment storage room or something. So that perceived accessibility is another productivity metric you can look at. And quality. Again, we're not on a conveyor line, we're not distributing parts or manufacturing anything, we take care of patients. So in healthcare, when we think about quality, this is really the patient experience. Are we delivering quality care to that patient? Again, can be easy to collect depending on your organization and what they do for patient feedback. We have experience surveys. We can tap into those for feedback. We've also used staff perception of care or comfort. So when I remember we're doing a trial with a unit and implementing a product, and we really wanted that patient voice. So we just started asking patients, do you like this? Some were brutally honest, no, it's hot, you know? But then others were like, yeah, this feels so much greater. It's better for my back. I don't feel like I'm being dragged up the bed. There was a lot of great feedback that came from patients when we were asking these questions. Again, if we're thinking of a better experience being perceived by the patient, we can equate that to patient safety. And we've asked staff the question, do you think this is better for patient safety? Because it's funny, staff think about their patients more than they think about themselves. And really that patient safety is more important to them than their own safety. So if they feel it's safer for the patient, they're more than likely gonna feel it's safer for them. We've also looked at errors in use. So again, another product implementation trial. We were very curious to see, okay, they've got the product in the unit, but are they actually using it? So we had a dedicated staff member tracking its use and making sure it was installed correctly every time. Because if it wasn't, that's a huge error not only for our staff, but also for our patients. So we wanted to make sure. So you can look at errors of use as a quality measurement. And then was mentioned earlier today too of tying into other metrics. And one huge one when it came to us was the clinical outcomes and pressure injuries. So when we think about repositioning a patient in bed, the longer they lie in bed, greater risk for skin integrity, greater risk for pressure injury development. But if we implemented something that allowed staff to more easily move the patient, it should decrease that. So we tracked the outcomes and we saw, and with one implemented product, we found there was no impact at all. That skin integrity was not impacted and staff were more apt to use it. So we can tie into clinical outcomes. So, the slide is blank right now. And it's on purpose, because I want you to kind of think, I've talked through all these things that we've done, but really just show you in kind of picture form what this looked like for us. So we started by looking at our injuries. So quick graph here, because we have to have one graph at least. So one graph showing our breakdown. Yep, our patient handling injuries were roughly 50% of all of our injuries, and that's where we're gonna focus. So we started with analyzing our data. We then did a literature review, and we were looking to see, okay, what's the literature telling us? If we're gonna implement a program, what should be those components? What do we need to look at for that program? We contacted our peers, drafted a comparison of what their programs had, what resourcing they had, how they delivered education, do they have dedicated equipment, of such. This really helped us sell what we needed. We summarized all of our findings in a project charter. This was our first starting point of communication with our leadership teams, letting them know this is what we're thinking of doing. This is a rough draft of what we're going to need to do it, and these are our rough deliverables. At this point, nothing was set in stone, but it was planting the seed. This is coming, this is what we want to do. We held focus groups with our staff, and you may recognize some of the faces in this picture. We held focus groups with staff, and we shared the information with them, gained their perspectives and insight, and we said, if we're going to launch this program, how should it work? What do you want to see? What has worked for you? What do you find valuable? And based on that feedback is how we developed our education program, actually, for our patient handling training. And finally, to sum it all up, we put this into a logic model. This is more of a public health thing, and your organization may do things very differently. But we used a logic model to really communicate on one single page to our leaders, what's our problem, what's our goal, what are our key deliverables, how are we gonna do it, resources we need, and guess what? Here's all of our metrics that we're gonna track to show improvements. So that was something that was really effective for this project. Other projects, we've used A3s, we've used S-bars, we've used just PowerPoint presentations. It really depends on your audience. But ultimately, it summarized all that information and gave leaders an understanding of where we wanted to go. So we're going to talk now a little bit about leadership commitment. So I love that most programs say get leadership commitment. Great. How am I going to do that, right? And what's that look like? So going back to what Susan shared when we started this whole talk, we talked about it's not just signing a policy. I think a lot of us, at least I know when I started in the field, it's like, great, policy signed, my job's done, I'm out. No, not at all. You have to implement the entire program. And what leadership commitment really looks like can vary, again, between sectors, between companies. But for us, it was a lot. So our leadership commitment, we got resources. $4 million didn't come out of thin air. We had to fight for every one of those dollars. We had to work hard, and we got it. And what we see is financial commitment, not only now, but in the future. So sustainability of our programs was ingrained into fiscal budgets. Departments had funding, and like Susan mentioned, we were able to take the funds that we received from the safety groups and reinvest back into our organization because leadership allowed us to do that. Capital development's another area when we talk about leadership commitment. Again, I never really thought much about this when starting in healthcare and how important would it be. It's a big deal to build a hospital. And it's a big deal to ask for space in a hospital because it's not usually there. So really, when we're thinking about capital development and leadership commitment, when our leaders are saying, yes, plan for your training room, yes, plan for your wellness center, that's commitment. They're giving us those physical spaces that'll be here for years to come to use for our programming. Our leadership has identified executive champions. We have an executive VP who we report to monthly on the progress of our program. So he's responsible for MSD prevention, and he hears from my manager, Steve, over there, every month about what we're doing and how things are going. But he's also there to provide guidance, to remove barriers, so that two-way communication is going back and forth, so there's continuous observation of the program and understanding of where we're at. We also have leadership representatives on a multidisciplinary committee. So talk about breaking down silos. You bring every leader to the table that has some sort of stake in this, and you have a discussion. And we do this on a quarterly basis. So we have managers, we have clinical managers, we have our customer support services, so our Porter and EA managers, we have educators, we have, oh my gosh, I can't even think of everybody else we have, but there's a whole group of us on this committee, and we meet quarterly, we go through our stats or our metrics, which I'll share a little later of what that could look like. We go through all this information, we look for trends, we bring hot topics to the team and say, hey, we've got this problem, what are we gonna do about it? And we talk it through. Sometimes we can resolve it at the table. Sometimes they're giving us guidance of things our ergonomics team can take back. And sometimes we need to make recommendations to our executive leaders for that change. And ultimately what this accumulates to then is alignment. And with alignment, we have inclusion in our organizational strategic plan. So when I asked you that question before, it was for a reason, because this is where you wanna get. And to kind of show you what that means, this is our strategic plan. So our strat plan is our North Star. So it basically guides all of our work, it guides our resources, it guides our time demands. There are 4 pillars in our strategic plan, which you can see around the center there. So there are patients, our sustainability, our people, research, innovation, and learning. So those 4 pillars remain constant. But as this plan is reevaluated every year, the projects can fluctuate, and it really depends on what's going on in our organization. But what we've been able to do with the advancement of our MSD prevention program and with employee well-being is ingrain certain projects straight into this strat plan, meaning they're reported on and they're seen as a priority across the organization. So to kind of give you an idea of what this looks like. So with our strat plan, our work usually falls under this people pillar. So right under the people pillar, our organization has committed to a safe work environment for our staff. So no matter what work we do, we have this to fall back on. Even if none of our projects show up on here in the future, as long as that people part is there, we will be there because we are focusing on the well-being of our people. We have what are called in-year objectives. So in-year objectives are projects that are worked on within an annual basis and they have a very targeted outcome. So ours is lost time injury. And our patient handling program has actually functioned under this project heading or focus for many years. So we're focusing on the reduction of lost time injuries, and that is a priority metric, a North Wall metric for our organization. We have our transformation program, and what is so awesome is to see how our program has evolved over time. We now are considered to support the development of our new hospitals. So our ergonomics program is heavily involved in what we call our healthy future, and this is the building of new facilities. So we sit down with our capital teams and we provide feedback on design, on equipment procurement, on various aspects of these, so we are ensuring that we have our voice right up front. And finally, we have our corporate projects. And corporate projects are really things that need that corporate lens. They bring corporate committee to the table to talk about the problem or the challenges. And really our staff wellness program fell under here as part of pandemic recovery. So we're really focusing on staff wellness. So now this is being highlighted with required reporting on what's happening and what's being done. So remember when I was talking about that alignment? We now have alignment with a visual on staff well-being. So, alignment. That was a great segue. Here we are. So really with alignment, we're looking at it at all levels and in all teams. So with it being on the strat plan, it makes it pretty simple for our team now because all of our work focuses on those aspects. And what's really great about alignment is it drives engagement of our stakeholders. So when we see it on the plan, clinical managers are seeing it on the plan, other managers in the organization are seeing it, and they know they have a piece of that puzzle. It brings us all together to have that conversation. That there supports and fosters the collaboration and tears down those silos. Because if we're reporting on it, that means they need to report on it. So we need to work together in order to accomplish that. And finally, the alignment improves that communication. So when we were talking about using the same language, when it's on your strat plan and you have that alignment, you're all forced to speak that same language because that's what the organization is looking at. So to kind of demonstrate what we have going on that allows us this alignment. So here's just a picture of our strat plan. So our strat plan drives what directors in our organization put focus on. So their priorities are documented on this document, which is called a plan on a page. So here, the directors for each department outline what are their priorities and how that ties back to the strategic plan. From there, that plan on the page fuels a few different things. So for each member in our organization and manager, it fuels our personal objectives. So we have performance objectives that we develop that align to that plan on the page that then align back to that strat plan. So everyone's speaking that same language. Additionally, departments have scorecards, so metrics that they are following that have alignment to the 4 pillars of our strat plan and back to what those priorities are in their department. And then finally with alignment, we're looking at those projects. So remember how I said we have those in-year projects and those corporate focus or corporate initiatives? Each of those has pretty much a scorecard or report out back to senior leaders about the progress. And that happens, be it monthly or quarterly, depending on the project. Those again have that alignment piece and are tied back to the director's work and to our strat plan. So when we're talking about alignment, I don't know how much more aligned we can get at this point. But there's a lot of focus on it, and it's really important to foster that teamwork, that collaboration, and to keep that communication going. So I'm going to turn the mic back over to Susan right now, and she's going to talk a little bit more about our psychological health and safety.
Thank you, Janice. Isn't she brilliant? So that alignment and that strategic plan, as you saw, Janice highlighted some of the wellness aspects there, and what we're really trying to achieve is an environment or a culture where well-being is first and foremost. Janice has mentioned that our staff have more interest in ensuring that their patients are cared for and that their patients are safe than they do necessarily for their own safety and their own well-being. So we really need to turn the tide on this. And so what we're doing as an organization, you saw under that strategic plan that corporate wellness or corporate well-being is one of our strategic projects. And so what does that mean? What it means is that we have a concerted effort and focus on bringing forward psychological well-being in the workplace. So how are we doing this? We are adopting the CSA standard, Psychological Health and Safety in the Workplace, and we're looking at all 15 elements. For those of you who may be familiar with the CSA standard, you'll probably be thinking, what is she talking about 15? There are only 13. But in fact, there are two additional standards now that have been, two additional elements rather, that have been added for the healthcare sector. So we are focused on bringing all 15 of those elements sort of into compliance, if you will. And so this is not an easy task. Just as we have spent years in trying to develop our MSD prevention program, we will now spend years in trying to bring forward psychological health and safety in the workplace. It's not an easy task, and it's something that will be done incrementally. So you'll see here on the slide that we've got an estimate of 3 to 5 years to bring this program into place. That's based on case studies that the Mental Health Commission of Canada had done with other organizations, and it does take on average, depending on the size of the organization, and with ours being such a large organization, it's probably going to be closer to that 5-year mark. So with it being such a daunting task, how are we going about doing this? Well, really, what we've done, and this particular slide here is part of a regular update that I would be providing to our executive leadership team. So it's just outlining what the deliverables are on our corporate staff wellness project. And when we say staff in this context, we're talking about everybody. So it's not just our staff that are paid by HHS, but it's also our physicians. It's also our learners. It's our residents. So anybody who is working within HHS's walls is included in this plan. And that's sometimes difficult for people to see. They don't necessarily see themselves in that work. And so for that reason, our line of communication is really important. We have to ensure that when we're communicating things, we don't just talk about staff. We always have to make sure that we're talking staff, physicians, residents, and learners. So what we've done here is just broken it down into these 3 phases, if you will. The first one is the current state review. So what we did here is we looked at the health and safety elements in the CSA standard, and then we started going through an exercise of assessing ourselves against each of those elements. So we collected operational data, communications, policies, procedures, survey results, and other data that we could get from other hospitals and other sectors. We then went through an exercise of saying, okay, we're not starting at ground zero here. We do already have a lot of things in place, so let's start to categorize them and let's document them. So we had all of the 15 elements, and then we looked across the organization to see what policies do we already have in place? What programs do we have in place? What services do we have in place? What resources do we have in place? And so we started to map it to those elements to demonstrate where we had good uptake and where we had opportunities to grow. We did an environmental scan of other organizations as well that have implemented the standards so that we could learn from them. So that was our current state review. That was sort of earlier this year. We embarked on that, and it's taken us quite some time, and you'll see on the next slide why it's taken us this amount of time because of the internal environmental scan that we did in order for this to be a participatory process. So next we're on our gap analysis, and this is the identification of the factors where we're not in compliance or where we still see that there is a big gap. We've been able to use our employee engagement survey, which as of this year has turned into an annual survey. So we used to do our engagement survey, which is called My Voice Matters, again, for staff and physicians and residents that would complete the survey, and then we would have action planning that came out of that. So again, we can take those themes that we have learned through the staff engagement survey, and then we also worked with the Guarding Minds at Work tool. And so that survey, in combination with the staff engagement survey, really gave us a lot of excellent information so that we could start to see where we've got some opportunities. So we're still in that gap analysis phase now, and then the next phase from there will be looking at those elements and prioritizing. So what do we have that is going to be high impact and low effort? We think that we've got a number of elements that are called Just Do It. So we're going to take those and we're just going to put them into action, quick wins that can be visible. And one of the other things when I talked about communication that's really important is connecting the dots for people. So when people do their annual staff engagement survey, and then we're asking them to do it again in the following year, they're saying, well, what did you do with the information I gave you last year, right? So it's important that we connect the dots for people. So for example, we introduced pet therapy. So we've partnered with some vendors, and we've actually now purchased our own facility dog. He's in training, Hank. But we do have a pet therapy program, so every Friday we have the handlers and the pets that are at our different sites. And so people are loving this. We have wellness carts that go around, like refreshment carts, and they've got different refreshments on them. They've got kindness cards that you can take and give to a colleague. But all of these things are as a result of the feedback that we've received from staff. So we have to help them to connect those dots and say, this is why we have pet therapy. This is why we have these wellness carts, right? So that they understand that we are, in fact, listening and that we're putting programs and resources into place to respond to the information that they're sharing with us. So we will go through this exercise now of prioritizing the different elements, again, sort of doing those quick wins, but then also looking strategically, what can we take on over the course of the next 12 to 18 months so that we can close that gap on what the standard is telling us that we need in that element and what we're actually seeing in place. So I mentioned the information gathering. This was something that we were very deliberate about and why it took us so long to do this particular piece, because we very easily could have just taken the survey results from the engagement survey that we have and then maybe talked to a couple of people and just said, be done with it and start moving forward. But really, are we going to get the engagement? Are we going to get the buy-in? Are we going to understand what the needs are of our organization if we had handled it in that fashion? So we decided to take a different approach and really sort of do some in-depth information gathering, and we did that through different focus groups. We were able to leverage existing groups, including some of our affinity groups, our joint health and safety committees. We have wellness champions. We've got about 38 wellness champions across the organization that assist us as well. And of course, our EDI, so our Equity, Diversity, and Inclusion team was able to provide us with some input as well. And then we did some very targeted subject matter expert interviews. So either a group of people or specific individuals, just to again find out what was already in place and what were some of the opportunities that they saw and some of the gaps that they saw. So that would included our performance evaluations, our safety occurrence reports for staff, our collective agreements. We have 7 different unions at HHS, so we have a lot of different collective agreements, so just understanding the nuances of those. And from an organizational development, looking at the courses that we already offer through our Center for People Development and also our new leader orientation. And then finally, we looked at all of our data. So, how many staff are off on mental health leaves, our lost time injuries, our absenteeism trends, overtime, sick time, et cetera. So that took us a matter of a number of months because, again, you can imagine we engaged hundreds of people in this particular initiative so that we could really have some rich information. What I'm showing here is just like a snapshot. So each of the elements, this happens to be from the standard, the protection of physical safety. So every one of the 15 elements has a sheet like this that outlines the definition and the potential benefits. So that's from the standard itself. Then on the right hand of the page, what we've done here is we've just broke it down into our current state, our indicators, our opportunities and enablers. And then you'll see that there's a percentage of risk level up at the top. And that again is just from information that we have gleaned from both looking at the standard and what's required in those elements, and then also using the Guarding Minds at Work, and then mapping it to our results from our engagement survey as well of our staff and physicians. So this just, again, is trying to demonstrate the rigor that we're putting around this and being able to document what it is that we're finding so that we can identify what those opportunities and enablers are so that we can move the needle on these. So I think I'm back over to you.
Only a few more slides, I promise. All right, so coming back to MSD prevention, so how this fits into our psychological health and safety program, and really this falls under that physical safety component. So we know we need to continue, and we need to continue to advance this program. So we have that strategic alignment, which is great. We've had that buy-in. Historically, our program has been reactive. We're talking about workstation assessments, incident investigations, return to work, accommodation support. That's great, but we know that's not our future. So what does our future look like? So when we think about it, our future is prevention, right? We want to prevent injuries before they happen, and we want to do that as soon as possible. So we have kind of 4 bins here that I'm gonna go through to kind of show you where we are directed. So we have our education, design and procurement, our wellness components, and then that continuous improvement opportunity piece. So with education, really over the past few years, our focus has been on our patient handling program. I probably said that 5 times to you, I'm just saying it one more. That has been our focus. And truthfully, it has been a successful program. It's laying the foundation now for as we move forward, because we're gonna be looking more into our material handling world. So really, it's gonna be taking the learnings from that and applying it as we move forward. And really with this education, we collect metrics through every phase we have implemented. And if you have the opportunity to do this, always collect pre and post data. It's the easiest way to develop metrics, right? You ask a question before, you ask it after, you show the change. So don't forget to do that if you are implementing anything. It's from those surveys we learned things like sling laundry. I was giggling in the back when it was mentioned today because you'd think something so simple, and it's not. It's like the most convoluted process you can imagine. But it has a huge impact for our staff. So through the surveys, we identified that's a gap. We have addressed it because it came up in education. Staff kept talking about it. Making point-of-care resources. It's a lot of information. Our orientation is 3 hours of hands-on education. Clumped with everything else they're learning in their orientation, they're not going to be remembering every point we make. So we've developed point-of-care instruction sheets that are available in units for staff when they can't quite remember every detail they need to for pieces of equipment. When we're talking about procurement and design, so for us, design is huge. This is our path forward. We know we're building 2 new hospitals right now. There's gonna be probably more in the future. So we wanna make sure we have our guidelines up front with our capital team so they're aware of what the specs are, what are those design guidelines. We've also been fortunate enough to be involved in such an early phase that we can include those specifications in those design guidelines for the vendors. For anyone who is wanting to build our hospital, they're gonna see these and they're held to these. So those project-specific output specifications, I'm trying to remember the PSOS. Very important document if you're ever building a new hospital. We were lucky enough too that during our latest build, which is happening in West Lincoln, we actually had mock-ups developed. So we had medium fidelity and high fidelity mock-ups. A high fidelity meaning a full functioning patient room that we were able to go in, look at how things are installed, look at how things are positioned, and say, good or no good. And during that time, we were able to identify over 25 design changes we wanted made just in those 2 mock-ups. So we had the high fidelity patient room in a medium fidelity, which if anyone's been through this, that's more like cardboard, plywood, and paper. But still, it gives you a really good idea of space and how things work. And you can actually see an image on here with a red circle. So this is actually a charge station that we had mocked up. And I don't know how well you can see it there, but those are actually 2 workstations crashing into each other. So it would have been real great if we produced 13 or 14 of these and we had staff sitting on top of each other. So we were able to identify these challenges right up front, architects right there, changing the design right there in front of us. So it has its benefit to be included. Same with our procurement teams. We've been able to get our voice to our procurement teams to let them know if there's anything non-standard that's coming in across your desk, give us a call. Let us know, because then we can review that product and ensure we're not bringing something else into this organization, creating new hazards that we weren't even aware of in the beginning. Wellness. So we just talked about our employee wellness, but really we, as our ergonomists, we've been able to kind of push the programming of this team as it would relate to worker well-being and, again, MSD prevention. So we've worked with our wellness team to develop task-specific, or technically job-specific, stretch posters. And we have stretch programs in our hospitals. So we had, I think, there was over 60 departments participating right now in stretch breaks. So they're scheduled stretch breaks. We have our students come in and they do stretches with each team. We also run massage clinics. So we promote these massage clinics to employees. And last calendar year, our wellness team supported, I think it was just under 3,400 massage appointments for staff. So quick 15-minute massages that staff can sign up for. Finally, when we're thinking about continuous improvement, so just some key things that have come across in our organization. So we are very fortunate that we have a corporate initiative. It's our continuous quality improvement initiative. It's implemented in multiple departments. It's really getting our staff to become the problem solvers. And what's really nice, and to know that our program is working, is when you see these are called, why am I forgetting what they're called? The slips there? Improvement slips. We see these improvement slips. And when we see MSD prevention requests documented, we know we've made a difference. So the example here, these slips are filled out, they're put on department boards, and then they're inputted into a database. So I did a quick search of the database to see, what's floating around. And I found one that actually staff identified. All of our workstations look different. We all don't have the same equipment. Some staff have keyboard trays, some don't. Chairs are broken, and probably my team at the back's laughing because they know what department I'm talking about. But it really flagged to them, like, there's a problem here and we need support to fix it. So there was an opportunity identified by staff. They knew they can call our team for support, and we were able to come in and rectify the issue for them. So that's true implementation. That's staff understanding that there's a hazard and identifying it. And another continuous improvement opportunity, as Susan mentioned, we did have the opportunity to participate in the Health and Safety Excellence Program this year, and one of the focuses was our bariatric program. So really looking at how we can support our patients with bariatric care needs. And it was through staff feedback. So we do a lot of training, we do a lot of problem solving, and it was always the same message. I can't find what I need. I have no idea what I need. What do we even have to support our bariatric patients? How do you use it? It was all these same things coming back. So after doing a little bit more deep diving into it, I found a huge barrier was actually getting equipment to the unit. So what we did, we were able to develop a process. We are a newly implemented EPIC site, so that is our monitoring or our electronic medical records. And we were able to implement directly in there now that a practitioner on the unit that requires our bariatric equipment can simply click, I need this, message goes to the porter brings the equipment to them. They don't even leave the unit. And we were able to find that we had basically reduced the time for staff to receive equipment from days to 39 minutes. So that's a huge improvement. And talk about productivity, there you go. Staff is not even leaving the unit, and they're getting it much quicker than it could have before. So finally, quickly to wrap up, because our time is coming due, monitoring for success. So I want to leave you with this note to think about that monitoring your improvements, it needs to be intentional, it needs to be consistent, it needs to be timely. If it's not going to give you the benefit that you want from it. So make sure that if you're monitoring things, it's relevant to the message you want to provide to your leaders or to your teams. You can see on the screen there's a snapshot there, and this is actually our MSD prevention scorecard. So this is something we developed for our MSD hazard clusters, that committee I talked about earlier, and these are the metrics that we review quarterly to see how are we trending. So included in here are policies, education, equipment, and injury trending. So we talk about all the metrics in those bins, and it really drives our activity. So you might see a line of red on there. Everyone sees that bright line of red? Yeah, that was a flag for us. And that was really the backlog in our education. So we were able, by looking on our scorecard, to say we have a huge backlog in education, COVID fueled, thank you. And what are we going to do about it? And it was by seeing this on our scorecard that we were able to dive deeper and identify we are having injuries in new hires not trained and we need to do something about it. That is how we sold that to our leaders. We were able to give them a number, a cost of how much those injuries, resulted in, and that we needed to address it. So to give you a few take-home messages, understand your organization's mission, vision, and values. That strat plan is your best friend. Use it as your key priorities to guide your metric development. When quantitative metrics are challenging to collect, because they are, there's times where you don't have the data you need, get your data. Use qualitative data to identify gaps or demonstrate impact. And finally, alignment to key deliverables fosters communication and collaboration, which is definitely integral to success. So we thank you so much for your time, and we'll open the floor to questions.
Questions for our presenters?
Hi there. I used to work in healthcare, so I admire your case study. Very well done. I do have, again, CART vs. WSPS. Quick three-part, if I could. Question one, going back to the metrics that you used to collect the data on productivity and the safety and quality and so on, there were quite a few perceived inputs. What I would like to know is, how did you manage the consistency when receiving that input from across the group, other surveys you may have done? Second question is, what was your sample size? Did you do it in one department, one site, one location? Was it across the 15,000 staff? Question to you is, going back to the psychological health and safety, did you use the CSA 1003? And if you did, I would like to find out what you were referring to by 15 standards, or was it the 13 psychological workplace factor that we're looking at? And question three is, guiding mindset work survey. What was your participation rate? Thank you.
Questions. Okay, you might want to stand there because we're going to have to probably go through all those again. All right. Question one. So you're talking about perceived data, correct?
Yes.
Okay. So with the perceived data, the way that we did it was we did it on a Likert scale. So everyone basically had the same question, and then they can say 1, 2, 3, 4, 5, whatever we had listed as each. So that's how we kept the consistency. Sample size was the next question?
Yes.
So sample size varied depending on the project. So we've used the same questionnaires across various departments. So you could have, basically, I've had a response rate ranging from 34 to 50% depending on which team I'm working with, and the sample size could vary. So some of our clinical departments can range, say, from 100 staff, and you could have some that maybe are like 30 staff. It really depends. So really, I try to capture sample size as much as I can. Sometimes it's great, sometimes it's not. So as much as I try to report it, I know sometimes it's not going to be completely reliable either based on that sample size. So great question, because you definitely do want to note your sample size when you're collecting your surveys. Okay, and I think you went to psychological health and safety.
Correct.
After that. Susan?
So I'm sorry, what was the question? Whether or not we use the standard, then you had something about the factors?
Yeah, so the slide mentioned 15 standards, and you're looking towards achieving those 15 standards
Yes.
implemented into your day-to-day routine.
Yes.
Were you referring to those 13 psychological health and safety factors, workplace factors?
Yes, plus the 2 that are healthcare specific. That's how we got to the 15.
Oh, okay. That answers my question.
Yes.
And the last one was guiding mindset work survey.
Yes.
Did you have any challenges with participation rate?
So we didn't administer the Guarding Minds at Work survey at HHS. What we used it for was to help us to assess where we felt that we are as it relates to those different elements. And what we did is a comparison against our engagement survey, our staff engagement survey, to see where the questions mapped over to the Guarding Minds at Work survey. So we were able to use both pieces of information in order to do our assessment.
Okay, thank you.
You're welcome. Yes.
Hopefully my question's a little bit more straightforward. What's the name of your therapy dog? I'm just kidding.
Hank.
So it's awesome that you guys had the $4 million investment for new equipment, in addition with the 100% return for the excellence program. My question is, can you walk us through the change in the decrease of lost time injuries and absenteeism, or was it just a straight up okay, we got this investment, all these new tools and devices, and then was it like 0 injuries, or is there like a spike in non-lost time injuries?
Yeah, so we saw a decrease in the lost time injuries in medical aid based on the Safe Patient Handling Program. So that was really the initiative that is driving our corporate objective of reduction in LTIs, lost time injuries. And so that's the work that's been done on that safe patient handling. It's not to say that we're not working on other things as well. So workplace violence, as an example, that is another high area of injury for us. So we have very focused programs on violence that's coming from patients, be it aggression or responsive behaviors, as it comes from family members, or as it comes from visitors, or as it just comes from the general public, because we have hospitals that are downtown Hamilton. So we look at all of those different factors, and they all contribute to our overall reduction in our LTIs. We have seen a year-over-year decrease in our LTIs once you take out the communicable diseases, right? So we saw, of course, a huge spike because of COVID, obviously. So just to level set, we take the communicable disease numbers out, and then we have seen a reduction year-over-year of our LTIs. And then, sorry, you had a last piece there.
No, that was everything.
Okay.
Great.
Thank you.
Thank you very much. So just a few concluding thoughts before we take a short break here. Just a reminder, Susan and Janice showed some excellent resources. Those resources, they are willing to make those available, so we will be posting them to the website for anybody looking for some of those resources as well. Thank you. Just a quick highlight on the back of your program in the top right corner. There's a little QR code. I think we call those QR code, and that will take you to the MSD Prevention and Psychological Health Safety in the Workplace brochure. There's also some hard copies over there, which aligns MSD, a resource to align MSD prevention programming with some of the steps you might take when considering psychological health and safety management systems as well. So just wanted to highlight that for folks. Lastly, just before we wrap up, kind of following Jack's lead, I realized I also didn't introduce myself. I'm Steve Fisher. I'm the Associate Director of Research for the Center. Really excited for all of the great presentations today. And if I can just have all of our network researchers just kind of raise your hand for just a quick moment. Raise them high. I know you don't want to be, so Pete in the back, a couple over here. There's a few folks around. We have a wonderful seed grant program, so if you see any of those folks, and after seeing some of these talks, you have some interesting ideas, we have 15 minutes. Why don't you have a quick conversation and chat? Again, we do have a number of seed grants that we're looking to support to address some of the challenges that have come up through the conversation today. With that, we'll take about 10 minutes or so for a quick break and get back here at 1:15. Oh, sorry, 2:30. We'll get back at 2:30 for the next case study.